I'm Clark Kegley. I'm the Assistant Vice President in Information Services at Scripps Health. I oversee service delivery. It's my pleasure to work with the panel today, and today's session is going to be a little bit different than what you saw this morning. We encourage interaction. We'll ask you some questions. We'll raise up some topics of discussion that we think will interest you. So one of the things that really excited me about putting this panel together is we've got this really diverse and unique skill set, experience base, and I think also perspectives around patient engagement. So Jeanne, let me start with you and ask, what does patient engagement to you mean to you? And from your perch, the work that you do, what are you doing to help clients drive on patient engagement? And we'll just go right down the panel with that.
Well, I'll start with a case study as to what patient engagement means to me, because there was a 55-year-old end-stage cancer patient that I was remotely caring for, and then intimately involved in the patient experience that he received. There is a 90-year-old woman who is in Las Vegas who I am remotely involved in her care, and there is a 81-year-old woman who I am also remotely involved in her care. So patient engagement and that piece is a passion that I have. I have a really fun job because I have had the opportunity for as long as Ms. Claro will allow me not to be gray, to work with great people like yourself, and to sit across from the table, to sit next to you at the table, and to listen to what the challenges are that you face. So to me, on that side, Clark, I think specifically what we can do today is look at, I think a couple of our predecessor speakers thought about always keeping those people in mind. Thinking as how do they want to receive care? How do they need to receive care? How can we make it easier on ourselves? Because truly at the end of the day, if you had a good day at work, they probably had a good experience. So we all have that baggage, we all have that stuff, but how can we streamline workflow? How can we look at what the pain points are? Working with folks like Andy, Clark, John, I'm going to pick on you, a couple of other people out in the audience, working with you to make your life easier streamlines that process, and I think that's the first piece that we look at. And so it's a passion, and it's an opportunity that we have to make our systems better.
Great, thank you. Andy, same question?
Yeah, so as a CIO, there's a lot of times where my role is actually focused on deploying technology that aids the delivery of care, improves the experience at the front line. And I would say that from a Scripps point of view, we've got a robust brand that's centered around patient-centered care and making that experience be world-class. And our patients, it's quite a relationship in the local communities that we serve. And so as you look at patient engagement moving forward, there are all the reasons from a meaningful use, from a regulatory point of view, and the measures that are coming out today. And I think that if you look at the pressures that have been put on our providers today, specifically nursing and primary care, they bore the burden of a lot of the meaningful use initiatives from an administrative point of view, and we've got a lot of work to do to integrate these tools in a workflow that's actually great for the caregiver and good for the patient. And so those are the CIO type of things, but from a personal point of view, and probably many of you in this room have got your own story about a family member that's gone through either chronic disease, late stage, those type of activities. But when I think about my mother who went through stage 4 colon cancer, and I look at patient engagement and some of the tools and some of the technologies that we now have available, it makes me wonder, would she be here today? Might be here today based on some of the tools that we've developed. If the screenings for cancer and some of those other things had been deployed 10 years earlier, probably many of us would have family members that would still be with us today. So finding a personal way to connect and not get caught up in all the rhetoric is the things that are important to me as a CIO. It's really about the patient, and you've got to keep that why in front of you at all times.
Thank you. Karen?
Patient engagement. As a clinician and a frontline nurse, it for me was from the beginning of nursing. I always asked the question, why am I doing this? And one of my first experience as a registered nurse, I started on night shift. And I had a great director who said, you can go to day shift. I said, no, night shift is very more coddling. I felt like I had more time to be with my patients. And so I wanted to be on night shift. And I had this great nurse who taught me, I was scared of the cerebral palsy patients, and they didn't really talk to me, and I didn't know how to engage them. She said, it's okay, just talk to them anyway, and keep them clean, and this is how you suction. And then I had this trauma patient, and he was a 21-year-old status post motorcycle accident. And the mom and dad brought in pictures of what he used to look like. And what he looked like now in that bed in the semi-coma was nothing that I had ever seen. But I went in there every day, every night, and I would say his name, and I would say, hi, I'm Karen. Night shift is here. I'm going to be your nurse today. And I would say, time to clean up. 10 o'clock, time for meds, going in your G-tube. Hope the water's not too cold in your tummy. And I would talk to him every day. And as you're getting to hear my voice, you hear I have a pretty high-pitched, squeaky voice. And, annoying to some, soothing to others. It is what it is. And flash forward several months, he gets discharged, and he goes to rehab. And one day I'm standing at the nursing station with some other nurses, and somebody comes by and said, hey, Karen. And I said, hello. And, I'm thinking, well, he's a big, tall guy. I had no idea who he was. And then I saw his mom coming down the hallway, and I knew who he was. And even though I thought all those months that I was caring for him, he couldn't hear me. He didn't have any reaction. He wasn't really squeezing my hand. He was just there. But somehow he remembered who I was. And he remembered a lot of the other nurses on that unit as well, and came back to visit and bring us cookies, because the way to a nurse's heart is through her tummy. So that's my first experience as a new nurse with engaging patients. Whether or not they're able to see us, speak to us, we have to continue to engage them. And how did I do that? I was able to. I had the time. I actually had only a certain amount of patients. I was able to go in there. I was able to sit with them, hold their hands, do my charting on my clipboard, on my pen, with my pen and paper. And so to me, engaging the patient was not only about them, it was about the people that went to see them. That I now look at, what are we doing for our nurses to have them have enough time to be able to go in and sit and see their patients and have that time with them, because that's how you're going to get your physicians engaged, your bedside nurses, your respiratory therapists, not just writing down a beeper on a whiteboard. How do we get them to actually sit with them and have time to teach them?
That's a great example. We get into healthcare generally, all of us, for the mission. I don't know how you can listen to that example of Karen's patient engagement with that accident victim and not get a little bit of goosebumps listening to that story. So thank you for that. As we think about patient engagement, healthcare reform and meaningful use have imposed just a whole new slew of regulatory requirements, reporting requirements, financial incentives, you name it, on top of our industry. And it has a lot of impact to providers and other clinicians, physicians. One of the things that intrigues me is the patient portal requirements. And as you look at the stage 2 meaningful use requirements and then the modified SU2 requirements that came out in October of last year, the patients accessing a patient portal requirement was one patient in 2015 and 2016, greater than 5% in 2017, and then greater than 10% in 2018. And Karen, let me start with you. So as you think about the challenge of getting one, not too terribly bad, you can generally make that happen, greater than 5%, depending on your patient population, is a little bit more of a challenge, and then it doubles. So how should providers and healthcare organizations and partners that help them, how should they be thinking about those challenges, and what can we do to help drive those numbers to the larger percentages? Karen, you want to start first?
Yes. So one of the things that I also do is, before I got into nursing, I went to Fashion Institute of Technology in New York, and I studied marketing and sales management. And so that's the other half is, but I do volunteer with the Southern California HIMSS chapter, and I co-chair the marketing department. So if you guys want to volunteer and write some articles, come see me. And I think that's what we have to do. We have to market, market, market. I've heard of some hospitals have Surf the Web Fridays, and they wear Hawaiian shirts. And we go through, the different, units, and they engage the patient. So people are wondering, why is everyone wearing a Hawaiian shirt today? Oh, it's Southern California probably. No, this is Surfing the Web Day. Let's teach you. And sometimes they have volunteers that know how to use the computer, engage the elderly, engage the kids. Everyone that's on, no one nowadays does not have some sort of smartphone or some sort of smart device or know somebody that does. So my parents have one phone between the two of them because they figure I'm never leaving him and he's never not with me. So we only need one phone. So for them, it's engaging them with their apps and what they're doing on that one phone and teaching them how to do it, making it fun. When I worked at a company once that ended every policy with "have fun." That was their last line on their, policy statement. And so I think we need to have fun with it. And, when we started, most hospitals tend to say, oh, every person that's an employee, when you're a patient, you log in. And that's how a lot of hospitals were meeting that 5%. We need to do more and we need to do it better. And I think marketing it in a positive light and not just another task the government has put up on us. I think the task the government gave us was a good jumping off point, but now we have to do it ourselves and market it too. And don't underestimate the power of our patients. They know more than we think they do.
So I think that early on, most of us that were deploying these technologies realized that you can't just turn on the technology, not do the education, the change management, and the communication pieces that you mentioned. And so I think we've evolved our models, and I think there's some really great best practices out there. At two prior healthcare systems, one with the Epic solution, one with the Cerner solution, we actually had a cross-sectional group of patients that we engaged over a 3-year time frame. And so one organization, it was about 150 patients. We would meet with them on a bi-monthly basis, and we actually engaged them in things like after-visit summary, discharge instructions, MedRec processes, MyChart configuration, and other activities. And I think keeping them in front of us all the time to actually guide not just what our providers and clinicians said that solution needed to be, but to actually guide how we deployed and built those solutions. I think also early on some of the solutions weren't robust enough. I think they're getting to the point with e-visits and messaging and some of those other things to make it really meaningful. I think we also had some pretty big misconceptions early on about who would leverage these tools and who would not leverage these tools. I can remember a patient, Bud, at Maine Health, 89 or 90 years old, and he was probably one of the most active users. His health was pretty important to him at 90 years old. When you're young, you take, you're 6 foot tall and bulletproof, you're Superman, you don't have to worry about those things. But Bud took it very seriously, and so if you look at the demographic, it was the patients in the 50 to 75 range that were the most active users. And so thinking about how you deploy those technologies in a way to keep them engaged and connected, if we don't do that as an industry, we're never going to change the outcome, and we're certainly not going to drive down the cost. And so I think some of the APIs and some of the other tool sets are starting to come together in a fashion, especially as you look at taking risk and ACO activities, to really bend the cost curve and create a much stronger bond between the patient and the care continuum team. So pretty excited about the way those things are going. I've made a lot of mistakes along the way and would love to share those with the group if where relevant.
And I think from my perspective, working with an accounting, audit, regulatory, advisory firm, we look at those very same things. You start, the marketing piece is very important in how you're engaging your clients, but guiding that deployment, even to a next level, working with folks like Andy, working with several of the folks like yourself to really look at what's that new operating model where, many of you you've deployed Epic, you're in that realm, you've deployed Cerner, you have one of the large EHRs, whatever it is for you've deployed that EHR and have a whole team around it. You've deployed your back office and have a whole team around it. But are those solutions really conducive to the new models? Can they move to the cloud? Which pieces can you move to the cloud? Do you have that cloud strategy? What are you really looking at, and what are your long-term business goals? And you have to look at that whole picture, and it includes marketing, it includes IT readiness. Are we ready for this? Does it fit with our strategy? Docs used to come to us and say, hey, I've got a great app. And Cheryl this morning tested us to say how many of us are on or have a cell phone, and we do, but Karen, my mom is like your parents. She goes to the store and leaves her cell phone at home. So you have to look at that whole picture. How do we engage my mom, your brother? How do we engage, our 16-year-olds, and how do we engage the hospital administrators who have to support the deployments that Andy or others are doing? How do we, the service management? I got a great app, Clark. Are you going to be my help desk? How do you do that? And I throw that back out to the group to think about: are we ready, and how are we going to add that app? How are we going to engage our patients?
Clark, one other comment that I didn't mention, but the experience in deploying some of these tool sets and trying to get the utilization from a consumer point of view high. If you look at the data that comes out, the physicians and the caregivers, where we've deployed the tool sets in a workflow that works for the way they deliver care, the trust that the patient has with that caregiver, when that caregiver promotes that technology, the delta between the uptake on the patient side is so significant. And I think that sometimes we forget who the advocate is for those technology deployments. It's that frontline caregiver, and if we haven't done the right things from a tool point of view or a support point of view, we'll never get that uptake. But if we do those things appropriately, the adoption is so much higher.
It's a great comment, and all of the comments were really, really spot on. I think the thing that we miss so often is how do you operationalize a lot of the technology, which is what all of you were really describing. Another piece of requirement lopped on top of the industry that I find interesting is secure text messaging. So in modified stage 2, the same type of requirement around patient portal is one patient in 2016, greater than 5% in 2017, and then greater than 25% proposed in stage 3. So that is a pretty significant jump in the requirement, and there's been a lot of pushback on the proposed stage 3 and even the modified stage 2, and groups like Congress and CHIME and the American College of Cardiology and the AMA have pushed back and said this is too unrealistic, it's too difficult for us to be able to comply with this, even as we think about moving it from more of a patient-centric versus provider-centric. So if I'm the physician, how am I going to make sure that that patient is actually using that patient portal or using secure text messaging to interact with me? Let me ask the audience as well as the panel, how realistic is proposed stage 3 today as you think about your operations? Any thoughts?
So I think that having great partners in informatics to actually bridge that gap to the front line is so key to get these technologies adopted. And we haven't thought about the workflow as much as we should, and seconds and minutes matter in the delivery of care. And did we really make anything easier for the patient or the caregiver? And so you see, and there's probably a lot of groups here today that provide consulting services for optimization. So we spent a lot of years just trying to get it, I don't want to say crammed in, but crammed in, and now we're back looking at those workflows. Did we make it any better for the caregiver providing that care to be able to do these things? And so a lot of work around workflow. And it's great to have informatics partners out there doing that work with us.
We never underestimate, the power of the nurse, and it's kind of like Cheryl alluded to earlier, was speaking about we as registered nurses, and you're stacked with so many things to do. So you hear meaningful use, and we hear people grumbling about it. So to the frontline nursing staff, it is one more thing to do. So it's a matter of, prioritizing and how do we get this done. When we admit a patient, we always hear, as soon as you admit them, it's time for discharge. Start talking about discharge. As soon as they walk in, and the patient's thinking that way too. They get into bed, when am I leaving here? And that's the mentality. So when we approach them about the various apps that are out there, I mean, I have an app on my phone called like some nanny plant or something, and I'm supposed to drink my water, and every time I drink my water, I press the button and it goes, and my plant grows. Well, the first 3 days I had it, it died. But patients, so what is it that's going to engage me to drink my water?
Now I'm concerned about your role to help me in
No.
informatics.
I'm not even drinking my water, I'm going with a plant nanny. But at the same time, those are our patients, and I'm a consumer at the same time, and the patients are out there with, really extraordinary apps that they can use. At the same time, physicians have information that they want. They have congestive heart failure straps that monitor how much water and fluid intake, and they want them to use that data, but they want to use that cute app that the plant grows. How do we, balance that with them? Or do you have patients that you speak with that have apps and things that they're using instead of, what they should be using? Yeah. Lots of them, right? Yeah.
Well, and I think those are exactly the areas where you want to, as you're bringing your teams together, you want to engage the clinicians, and I'm going to use that as a general term on all sides, but bringing the patient in and looking at, some of those, going to your marketing departments. You have patient advocates that are out there. They're being philanthropically involved in your community. They want to have a voice. They had a great experience. You help them or their family members, and they will share honestly with you, or their family members, if their loved one's no longer here, but you help them through. They want to help you. They want to help you in your community. So it's how do you get that right team together? And then you want to know that we trust you. You're the person that we look for. If I'm sitting at my mother's bedside, there's some inherent trust, but I am going to go to Google. I am going to look at my thing. So asking me, well, what do you think? Yeah, it might take a couple more minutes to listen to what I think and then dismiss, because my mind is obviously going to go to, does my mother have what Google just told me is the worst thing in the world? No. So it's that communication and building that team, and it includes bringing your security folks in and understanding and helping your teams understand that this is secure, because my mom won't use text messaging because she does not want to put her information out there. She won't even let somebody know what her numbers are over the phone, so she wants to go see you. You have to deal with, okay, that's what, but can I engage Jeanne? Can I engage those who have, her care in mind? And can I get them to help with these numbers?
Great comments. I think one of the messages going through there is healthcare is a team sport, and you have to engage not only all of the caregivers, but all of the family, and everybody's got their particular concerns and issues, and those that scare them the most on the family side, I think, need to be addressed. And Karen, I loved your example. I kill real plants in my own yard. Virtual plants don't stand a chance with me. Are there other thoughts?
Look for the plant nanny.
Are there other thoughts, please?
There's some things changing from an interoperability point of view, which I think are going to get to the core of this messaging back and forth and the data to be able to be shared across those various portals. I also believe that Epic will announce this year some interoperability between their various instances from a portal point of view. And so I think they've had that native capability in their wheelhouse for a while. I think they had to wait for things to evolve. But if you're depending on the healthcare system, it's going to be interesting to see, are the technologies from an interoperability point of view going to mature to the point that the patient record is everywhere and nowhere at the same time, so that the portal access is just a window to it? That was the hope of HIEs. We all know what's happened with that from a funding source point of view. But it'll be interesting to see how the technologies evolve and then what happens from a mergers and acquisitions point of view with healthcare systems. And so some of the issues may not be as big an issue 8 to 10 years from now when you look at how they will have done consolidation. So don't have an answer for that one, but I think there's a couple of emerging things that will seek to address some of it.
Well, and interesting, there was a quick comment at the beginning of the program about MACRA, which is the, for those of you who have also heard of the doc fix law, we talk about, we've done all of this work around meaningful use, but the MACRA laws in deciding how you're going to participate in a value-based payment model, the regulations are based on the 2016 data. But in those regulations include some, still being worked out, but include some of those regulatory changes as to what those numbers are, how do you engage your patients. So having a voice and sharing your challenges with those arms of, whoever whether you're a physician, whether you're a clinician and it's the nursing associations, whether it's through the HIMSS Advocacy Day, it's very important to share those messages with your advocates that are out there lobbying, because the rules are not finished, but the data is starting to be, as of January 1, it won't start until 2019, but they're going to go back to 2016 data. And they're going to look at what you're doing, and your regulations are all based on this year. So I don't have an answer for you either, but it's a challenging question.
The only comment I would make is that I think that we're going to reach a point, and I don't know if it's 12%, I don't know if it's 18%, I don't know what's achievable from a messaging based on the patient population, but I think until we get to the point that our patient and the consumers got a risk and a reward side of that equation, I think we're going to be hard pressed to have it go much more than that. The other aspect would be that, if they don't have a reward for using it or the other apps, it's hard to advocate people to a lifestyle of health and wellness that they don't want for themselves. And so I'm perplexed sometimes by the humanity and the societal issues that we have there. And I'm hopeful that we'll focus as much on the education of our patient in our communities, because education will make change. It just takes time and it's slow, and so it'll be interesting to see these measurements falling in line with some of those other driving forces.
Some of the terms that are often associated with patient engagement, care adherence, medication compliance, and education, those are all areas that, depending on who you talk with, have varying definitions and involvement with patients. What's the best way, from the panel's perspective, to approach those areas? And when you're considering the diverse population of patients that any of the healthcare organizations have, infants and their parents and families, all the way to folks at end of life, how do you then tailor that to the various constituencies that you have to deal with? Jeanne, do you want to start?
No. That's for you. Well, I think you answer that with part of the question itself, is that each one of those issues, from the care adherence to the education, have to be custom tailored. And as you start to, can I use the Shrek analogy? It's like peeling back the layers of the onion. As you start to look at your plan, and you peel back the onion to look at what are we doing? Is it care adherence? Where and in which areas? Is it a psychosocial? Is it I've got a diabetic patient, but they're depressed, and so I keep peeling back the onion. And I look at, now I have more people involved, or more systems, and it really it does become a custom application, or a custom way to look at how do you solve this. And I think then when you look at, well, that's daunting. So what do? We go back, like Andy, you said, you know what, we're putting in Epic today, or we've gone down the road with our Meditech system, and now we need to optimize that system. You have to start with a business model. You have to look at what areas, what populations are you currently caring for, what changes what's your current state, what's your future state. And you start somewhere, and you look at that plan. And then you start from there, and you look at who all needs to be involved in this particular plan. So it really is a operating model shift. I don't know whether we turn the hospital on its side, because it's not just the hospital, and it's not just our traditional, what a hospital would think of as ambulatory care. It's, we had the conversation last night, it's do we address them at CVS? Do we catch them at, going into the movie theater when they walk by Walgreens? Do we contract with, we had a conversation last night, Karen, do we contract with the Irvine Company? Well, don't they do buildings and apartments? Well, maybe we contact and we put our clinic in there. So we really look at a whole different model.
Great answer. Andy?
Yeah, I'd like to pass the question to the person to the left. I think that there are some things that are lessons learned that we can carry forward from past experiences, and I think that keeping the consumer and the patient in this with us and not trying to solve this for them on their behalf is really, really important. I don't think that we've done a good job of that as an industry. I mean, many of us, if you go look at what percentage the healthcare system is of the employee base in a particular city or state, it's pretty significant. If you look at the total GDP cost, are we even engaging our own employees in a meaningful dialogue about the way to change these activities? I am encouraged by some of the technologies that are enabling secure messaging, some of the work on standards-based exchange that are going to make some help. I think that all of us take this wonderful little device that we love or hate and we personalize it the way that we want to personalize it. And I think if we can get some of the apps to the point that they're about that person, and then the way that the data integrates is really irrelevant on the back end side, if we can get to a common vocabulary in some of those pieces, I think we can actually start to make some changes that are personalized to that patient population. There's so many things. Now that does change some paradigms. Who's going to be the person directing care? And then you get into all kinds of RVUs and a whole bunch of other type of activities, and how are people paid, and those are real barriers. And what I hope we don't do is try to solve it independently, because we won't solve it independently. And so I'm encouraged by the dialogue here, the members of SoCal and HIMSS and some of the other things. I think earlier in my career I was too much of a cowboy and went at it on my own. I think we have to partner and be transparent with our other provider systems out there to go solve it, because we won't solve it alone.
Well said. Karen, do you have some
Yeah,
thoughts?
I think that's just tapping on to Andy. It's important that we don't work in our silos. We're just beginning to finally get out of our silos with some of the electronic health record systems that are out there. Our hospitals, we're all in competition. No, they're my patient. No, they're my patient. No, mine. And so I'm not sharing my information, and we have to kind of be transparent with the others in the community. And we also have to increase our transparency with our patients. Now we're sharing, patient information and notes documentation. One of the groups I facilitate is we are launching our electronic health record as the social workers. And I don't want to share my my notes with them. I have confidential things that I write about. And then, I don't want to put my picture on that screen because then they're going to see me. And all these things are isolating us from the patient that we're so much trying to engage. So how are we, quote unquote, saying the words of engagement, but then putting up these different actions? If I'm sitting like this, does this look like I want to be here today? But if I'm open, and that's what we have to physically do with our patients, we not only have to say those words, but our actions in our community, along with the patients as we look at them day in and day out, have to reflect that we're engaging them, that I'm with you on this journey. It's not just you're here today, goodbye, the revolving door, you're back again. No, let's engage the patients in real time, and not just the words.
Great comments. So in addition to patient portal and secure text messaging, one of the other things that is often discussed as we think about patient engagement, particularly outside of the walls of the healthcare environments, hospitals, clinics, and other settings, is wearables. On a good day, healthcare runs about 15 to 20 years behind everybody else in terms of technology. So with an infrastructure that's not necessarily ready to take advantage of something like a wearable, and then every other industry and concepts like the smart home and folks that are wearing wearables. I think there was a Harris poll last year that said something like 37% of folks that own a wearable wear it every single day. And of that percentage, 78% are constantly tracking the data that that wearable produces for them. And then you think about companies like ADT. They have a customer base of 7 million homes with 100 million sensors. How do you tie all that together? Should you tie all that together? And is there value to the patient by doing so? Karen, do you want to start off?
Absolutely. Right now, in the beginning stages, you know how we talk about big data? Those wearables, they're all basic raw data. It's, 98.6, 32, 120. What does that mean? That's your temperature, your pulse, your respirations, vice versa. What do all those numbers mean? Is it for a 20-year-old, or is it for an 80-year-old? Is it for an 8-year-old? So all those raw data has to somehow get to that physician in a clear, concise format, in an integrated system. And then we have the competition of the Fitbits doing it this way, and we have all the other apps doing it another way. So the physician comes in and they're speaking with Mr. Smith, and he's using one form of aggregated data, and then we have Mrs. Smith using another form. I have this girly girl band instead. So for the physicians and the healthcare providers that have to interpret this data, we have to somehow get those thoughts together, because otherwise it's once again working in the silos and with data that's not true data, that's not anything that is of value. Until we can transport that raw data into some form of knowledge and wisdom to help care for the patient, it's all just basic raw data at this point.
Andy?
So I don't know that I'm a very good poster child for wearables at this point in time. I'm on my third Fitbit. It's not at home, so I don't know where I'm at on that statistic.
It's not on your wrist.
The iPhone watch, the app is on my phone, but the watch is broken, so I've killed 3 devices in the past 45 days. With that being said, I think that the gamification and the social side of that creates a community that motivates people to do things that they wouldn't naturally be motivated to do. I don't know how many times I've gotten poked when I've only got 7,000 steps, and I find a way to walk around the office. The staff, we're going to have a walking meeting today. Oh, so you're down on your steps, are you? So I think that it can have a positive impact. I'm not so sure that the mindset of putting the burden back on the provider in that the physician is the right thing to try to go do. I think that there's other ways to create social energy using some of those wearable technologies to improve the health, and it shouldn't always come back to the provider. And so I'm not sure that we figured it out, but I think that we could probably look at some other industries, Ubers and some other activities out there, and go, what are we not doing right? I'd like to see us partner with the Googles and a couple of the other progressive organizations to determine where can we really drive some behavior and create a sense of community and connect people in a meaningful way. I think some of the things that are the most encouraging to me recently are some of the items around, I guess there's a Fitbit for the brain now, some of the adaptations. So I don't know that I want anybody to be that inside my psyche, but anyway, there's some things for mental health and some other activities where it's progressing. I think it has significant opportunity. Again, don't think we're going to solve that in an insular fashion. And I'm not sure that we should put the burden of that back on our caregivers that are already tasked with some pretty chronic disease patients. So I don't have an answer, but a lot of exciting things happening there.
I would agree with you, Andy. I think it's I have the Fitbit on. How many of you here do as well? But I'll go like this and go, oh, look it, I can't tell what time it is because I didn't plug it in. Yeah. So it's, but with all of these enabled apps, and I actually, I'll have a shameless plug because I'm friends with the CEO who's working with Eric Topol, and that Fitbit for the
plug that I didn't.
There you go. The
You.
Fitbit for the head. Actually, there's a little company out of West Wireless, or at least they're funding it, that has a sensor. And they use it for pain. So you saw the pain scale up here before.
Yeah.
What do you do with that patient when he's in a coma and he can't tell you what the pain is? Yeah. And his family's sitting next to you telling you to give him more medicine, and you can't make that determination. What do you do with the baby who can't tell you, or the infant who can't tell you? Wow. Well, this sensor, it's a wireless thing, they put it on your head. Well, I happen to be married to a med device guy, and getting that through a med device regulation was, forget it. It became a gamification. And it is not a pain monitor, but yet there are regulated apps, they go through the secure back end, and now you can look at this, and guess what? The mom can look at it, and you can tell if the mom is putting in a response, or the little child who now at 2, they know how to use the game, and if they're interacting with the game, you know maybe the pain sensor isn't quite as bad as mom might be telling you. You know, so there's ways that you can tell. And are you ready for it? Do they work? Do the batteries work? Clark, can you handle that on the, the infrastructure side? We're a long way off. I'd agree with you, but there are some interesting changes and trust. I agree with you, Andy, too. Is it the provider's responsibility? I think the providers are doing a lot because they're the ones that are getting the stick right now. The stick is coming down on, when we look at regulations, when we look at where the costs being cut, how's their livelihood being changed. My doctor doesn't want to know 24/7 if I have enough steps and what my heart rate is. He wants to know if I'm going to have a heart attack, and he wants to know now. Yeah, so we have other interesting. I'd throw that back. I'd do the same thing and throw that back to you.
Question down here.
Yeah. You have to err on the side of caution. You have to. You have to look in today's risk-averse, highly regulated, growing regulation. It's not going back. And, I venture to say, even if we divided our Republicans and Democrats in this very Republican county, you're not going to repeal healthcare reform as we know it. The market has moved. So how do we change that? You have to err on the side of working with your compliance and internal audit folks. Dare I say that? But you do, because we live in a litigious and highly regulated area. Yeah, it's and from a provider side and again from the regulatory compliance side and working with the firm that I work for, you have to, and we would advise all of you have to think with your compliance hat on. If you do not have that power of attorney, if you as a provider of care and as a nurse doesn't have it checked that I have the power of attorney, then it falls on me to prove. It falls on that burden of proof, right. So they shouldn't share that. Do doctors use their own cell phones? Do administrators know that they use their own cell phones? Yes. Do the wrong people get information? We have to try to stop that. It's a difficult question to answer.
So the question was, crowdsourcing is being used with greater frequency in healthcare. How can that be leveraged in a patient engagement environment?
I would say that the regulations are not in our favor to leverage that in a meaningful way. You talk about our risk and compliance. I'd refer back to you.
And I will take my firm badge off. So this is personal, and I know I have some partners in the audience, so I'm going to give you Jeanne McNerney's side of that as well. Being that I have some other friends that are on the med device side, and they are using crowdsourcing to try and get good ideas funded. It's an interesting way to do it. Healthcare is highly conservative. Those who invest in healthcare, they're highly conservative. Those companies that are coming, if they're creative, if they serve a need, then the conservative companies will step up. Kaiser has an incubator. HCA has an incubator. St. Joseph Health here has an incubator. West Wireless has an incubator, but they go through a very rigorous evaluation. So crowdsourcing it's an interesting way. Healthcare's conservative, and yeah, not that it couldn't happen.
I mean, I look at some of the things even just from a physician adoption point of view in the hospital, and look at med staff and bylaws, and think about the tools that we're trying to deploy even within our own, and the bylaws and the regulations are so outdated to be able to go do these type of things. It'll take you 9 months just to get some of those changes done in your own inside your own organization. So I think there are going to be some significant pressures from a regulatory point of view that would not make that be as well adopted as it would be in other industries.
I think we've got time for one more. Please.
Prior to joining Scripps, they created a compact, and the compact had some guiding principles. And there was the last one, which was to reinstill joy in the life of the caregivers that are providing the care. And I will tell you, we don't have that figured out, but I can tell you that we're spending a significant amount of time with our informatics and our physicians, time and motion studies. How are they spending their time? And are they spending their time in a way that they actually believe they're spending their time? If you go back and look at that at the end of the day, is the thing that I thought I did, the thing that actually occurred. And what we're finding is those are not congruent. But physicians can't spend, you can't be in practice. I think about their lives today from an RVU and some of the other measures, and it's 7 minutes, 7 to 10 minutes. Any of you in this room would like to have your day managed in 7 to 10 minute increments? It's not a fun life out there today on the front lines. And at one of the board meetings at the last health system where they had taken Epic and it didn't go well at Maine Health. I was brought in after that, by the way, so I got brought in after that thing didn't go well to get the thing going well. And I had a lot of great, so the organization was willing to listen and the caregivers were at the table. It's the only way we made that transformation. But when you look at the pressure that they're under, one of the board members says, what's your biggest concern and risk? And my biggest concern and risk, knock on wood, wasn't the privacy or the security things. Those things do make you afraid or concerned. What made me concerned is at the end of the day, did I make the life better for the person delivering the care? And the honest truth is I'm not sure that we've done that very well. We've done a dismal job at it, and we've got to get them back at the table with us, because I look at what a RN, a physician has to go through today, and thank God they choose the profession, but we've got a lot of work to do, heavy lifting to change the workflow for what they do, because burnout is off the chart. If you go look at the physician engagement scores and satisfaction, it's pretty dismal out there today. And I think that there's some organizations out there, maybe Athena, that have done some great marketing as to that, but we've got work to do. We've deployed the tools, we haven't done it in an appropriate fashion. A lot of heavy lifting.
Well, and KPMG has a whole practice around people and change. I mean, and we do not profess to know all of the answers, but we sit down with you, we come in and look at, you can't just put more on each one of these. You can't just ask your nurses to do one more thing, and now you have to market this. Now you have to, doctor, you have to put on your sales hat, and now you have to look at the whole organization, and you have to look at organizational change management. Can you retrain people to take on new jobs as you automate other things? Are they willing to do it? How do you attract new and better employees? Because you've now got an electronic system that needs technologists and needs informaticists. How do you get them to come to Scripps? Will you make a move from Maine? Will you stay in San Diego?
We'll make the move from Maine.
I moved from Minnesota, so I would have moved from Maine too.
Several times.
Yeah. So it's a challenging. Again, sorry for the shameless plug, but it's the organizational change management and that whole piece is a big deal.
And I know we're out of time, so I'll just have one last comment. It's a challenge for yourself also as healthcare providers and for patients in the community and for us that we work. I call it the sparkle in the eye. When you first start a job, you look and you're like, I'm so excited to be here, and you have that sparkle in your eye. And somewhere along the line, you lose that sparkle. And if you find you're losing that sparkle, you as yourself, as a nurse, as a physician, have to step back and say, is there other opportunities here? When I'm a registered nurse and I walk through an airport and someone says, what do you do? And I say, oh, I'm a nurse. They go, oh, what floor are you on? What unit? Where do you work? No, there's other opportunities. And so there's people coming in, and we need to educate them in the universities so that they know. For years, we've all been burdened. There's never been a staff nurse or a physician that I've ever heard through residency say, this was the greatest thing. I've slept great hours and I'm doing it well. You know, I'm happiest day every day. So we have to have some accountability for ourselves. And at Scripps, we do strive to have work-life balance. We continually look into our managers. We take a time check. We balance ourselves. If we're not feeling well, whether you're at the bedside or anywhere else, we say, hey, are you okay? And it's okay to step back. So we have to balance that somehow, because it's not going to get any easier with technology.
Okay, we're a few minutes over. Terrific dialogue. Thanks to the audience for participating, and thank you to the panelists.